for a medical, 10 minutes for a trauma. Let me know when you're ready to begin.
Give me just a second. And you're allowed to do this. I've got a blank piece of paper. I'm writing down on my glove. Glove's clear. I'm just making some mental notes real quick. Is that okay, sir?
That's fine.
Okay. Okay, so what I wrote on my glove, just so all you guys know, you can do your own thing, doesn't matter. I wrote pulse, VP respirations on my palm, TTH is the time in the hospital, my scene issues, resources, and then ABCs, okay? That's what I do. OPQRST, sample, all those things, whatever you need to do, find your own way to do it. You are allowed to bring in a blank piece of paper and a writing utensil because you have to take notes. Okay? Sir, I'm ready.
Okay. It is 9 o'clock in the morning. You're dispatched for a patient with altered mental status.
Okay. 9 o'clock in the morning, patient with altered mental status. How far am I from the scene, sir?
You are 10 minutes from the scene.
10 minutes from the scene. How far from the scene to the hospital?
From the scene of the hospital is 15 minutes.
Is ALS available?
ALS is not available.
Helicopter?
Not available.
Were any other units dispatched with me to this call?
Law enforcement was dispatched because a neighbor called and said that they couldn't make entry to the house.
Okay. Do you have fire coming?
They are coming.
Okay. What type of residence am I responding to?
It's a single-story, single-family dwelling.
What part of town?
Your normal response area.
Normal response area? As I approach the scene, is there anything that stands out obvious?
Nothing.
I see barking dogs, hostile crowds. Is there anyone waiting for me outside?
The neighbor's there going, she's in there, I can see her, but she won't open the door.
Is PD on scene?
PD's on scene and they're fixing the force entry now.
Fixing the force entry now. Okay. PD's there. I'm confident in this current situation. Force entry, walk in the house, what do I see?
You walk in the house, you see a woman, she looks to be in her 70s, she's sitting in a chair in the kitchen,
Okay.
just sitting there.
Okay, real quick, do I smell anything?
No you don't.
Do I see anything obvious, pill bottles, trash, feces? What's the house look like?
There's what looks to be like a bowl of dinner,
Okay.
sitting on the table, half eaten.
Okay.
That's it.
As I walk in, does she track me?
She does not.
Ma'am.
She looks up at you, kind of confused as you say ma'am.
Okay, as I'm doing this, I'm grabbing her radial pulse. Do I feel radial pulse?
She does have a radial pulse. It is 68 week, regular.
68 week. What about skin color, temp?
Her skin is pale, dry.
Pale and dry. Ma'am, as I'm talking to her, I'm looking at her airway. Do I see anything obvious?
You don't see anything obvious, and she just kind of mumbles and.
Okay, is she breathing?
She is breathing. It's 18. It's non-labored.
I want to ask the neighbor if she knows anything about this woman.
Yeah, I spend all day with her usually.
Do you know any of her medical history? Anything she might be diagnosed with? Any medication she takes?
She's got diabetes. She's got a heart problem. She had a heart attack 3 years ago. They think she had some mini strokes, I think they called it.
Okay. As I'm getting that information.
Her medications are, asked about were metformin,
Okay.
lisinopril, and baby aspirin.
Okay, as I'm doing all this, I'm going to demonstrate the BP, but I want my partner to be getting this. BP.
And blood pressure is 118 over 64.
Okay. I'm going to ask my partner to get a VGL.
BGL is 95.
VGL is 95. As I'm looking at her, I'm going to check her pupils. What do I see?
Equal, round, reactive to light.
Which side?
Equal, round, reactive to light.
Okay. Is she able to follow any commands at all? Ma'am, can you squeeze my fingers?
She does, and you notice that the right side is really weak.
What about bilateral pulses?
Equal bilaterally.
Okay. Ma'am, can you give me a smile?
You notice some facial droop on the right side.
Facial droop
Maybe
on
a
the
little
right side.
drool.
Okay. What I want to do at this time is I want to initiate transport. I want to move her over to the gurney, and we're going to get going to the hospital. Backtrack a little bit. I would like to dispatch ALS.
Okay.
Being 10 minutes from the scene and they're 15 minutes out.
Didn't I say they weren't available?
Yeah.
I think I
Oh,
said
they weren't available? Sorry. Okay.
You asked.
So no ALS, cool. Let's initiate transport. As I'm doing that, I want to put her on some oxygen. What's her O2 saturation?
Oxygen saturation on room air is 93%.
93%. Do I have capnography available?
You do?
I want to put her on capnography, nasal cannula cap for right now.
Okay.
What do I get?
Capnography is 34.
34. Load her up into the truck. Let's get going en route to the hospital. I want to position her in a position of comfort. As we're doing that, I'm also going to do kind of a quick head to toe. I want to look and see if I see anything obvious, any injuries. I'm going to start at the head. Do I see her feel anything like she may have fallen?
You don't see her feel anything like she's fallen.
Okay, is she more alert, less alert?
Sometimes she tries to mumble and respond to you, but really can't get words out.
I really can't get words out. Okay. Now that I'm in the back of the truck, it's a little quieter. I want to get breath sounds.
Clear, 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 clear.
Okay. Finish my quick head to toe, just looking, see if her abdomen's soft, non-tender.
Abdomen is soft,
Is her
non-tender.
pelvis stable?
Pelvis is stable.
Gonna kind of work my way down to have equal pulses.
Present.
Cool. At this point, I'm suspecting possible TIA. BP is still a little low for that, but she is altered. Checked her BGL. Her BGL is within normal limits. All I want to do at this point is continue to monitor her ABCs and reassess and route.
Okay. How often would you reassess?
Every 3 to 5 minutes for this patient.
Okay.
At this point, would you like me to give a radio report?
That's fine. They said she was in her 70s now. We never gave a definitive age.
UNMH, this is CNM Medic 1.
Right.
Be advised, we're en route to your facility with a 70-ish-year-old female. Call came in as altered mental status. She was unable to answer the door. Patient is alert to verbal more than anything right now. I have her on oxygen via nasal cannula. Vitals for the most part are well within normal limits. I don't have anything jumping out at me. Patient does have a history of TIAs, and that's what I'm suspecting right now. She does have right-sided facial droop as well as right-sided weakness. I have her resting comfortably on the gurney. We'll be at your facility in 5 minutes. Do you have any questions, Order?
No questions or received. Time.
Copy. 30 minutes, fine.
Okay. So, a couple things that you missed. What did you guys catch? We did color and temperature.
Age and weight.
Okay, age and weight would have been a good one, and those are, you could have got age from the family. Weight we're going to estimate anyways.
Could you check for ears and stuff for any fluids or bleeding?
He could have looked. I'm thinking more along the lines of his questioning. What I caught that he missed was allergies, last oral intake, and events leading up to. Events leading up to could be hard, except for the fact neighbor came over to.
So would you ask the neighbor at this point?
Sure, you could ask the neighbor. As far as we know, the only events leading up to where the neighbor came over to check on her, and she wouldn't answer the door.
And he actually, which I still didn't catch till now, he gave me global picture. When I walked in, what did I say? I said, do I see anything? See, it looks like half-eaten dinner. I didn't ever register that, but more than likely,
That was
you
her
can
last meal,
assume
right?
that was her last oral intake, right? Which I didn't catch.
Okay.
Allergies.
Plus, that
I
also
think,
tells you one thing too, right? How long has she been sitting at the table? It's 9 o'clock in the morning. So when was the potential onset? It was more.
Was it a
more
steak, or was it a bowl of cereal?
it was a bowl of some. It was half-eaten dinner.
So could you
So-
just like somehow check the temperature of the food display? Like
Sure, I would have touched it. You know, did it look like it was fresh eggs, like she's been eating breakfast? Or did it look like, you know, half-eaten ramen soup, like she just had, you know, half of her dinner, and then all of a sudden stroked out there on the chair? Okay? You could ask her friend, hey, when was the last time you saw her? You said you spend every day with her. Her friend would have said, well, I fixed her dinner last night and I left. She was sitting there when I left. Okay? So why is that important in a stroke?
It's been longer than
3 hours.
Well, did you catch the BP though? The BP was already back down within normal range. The damage had already been
The
done.
stroke happened and now she's just.
She stroked out. Like
Well, didn't she
12
sit
hours.
in the chair for over 12 hours?
Exactly.
Then
She
it
just
must
took-
have- that
She
does
could.
a whole other thing.
She could, right? She could have some D-cubes form under her butt, depending on how, you know, how long she's been sitting there, how hard the chair is. She's definitely got brain death if it's been 12 hours since she threw that quad. So that's all stuff to mention. OPQRSTU really doesn't apply in this. And the only thing I can tell you guys for testing is tell me the patient's not having any pain or can't answer my questions, so I can obtain OPQRSTU. Boom, 8 points.
Done.
All right,
But that's
just tell
something
me it
that
happened.
Did I check for it? I did, but that goes back to what I told you guys. I knew that I was going to make mistakes, like it happens. But I'm glad that, like Charlie pointed out, OPQRST. I did it. I checked for
Yeah.
everything. There's no response, but you got to state that. Does that make
Just say
sense?
it. Because I can sit here and I can pick through and say, yeah, you kind of maybe determined onset, or, you know, you did some clarifying questions to kind of figure out what was going on. You checked the sugar, you know, he did a good neuro exam, that kind of stuff. So I can give some points there. But if you just blurt out, I can't ask OPQRST because my patient can't answer my questions,
Done.
it's done. That's 8 points. It's gone. It's not even a consideration. It's a free 8 points just by saying those words. Now, if you should be OPQRSTU in pain and you tell me you can't get it because whatever, I'm going to call BS and you're not going to get your points. So don't try it then. But if your patient can't talk to you or if they're not having pain, just tell me. It doesn't apply or I can't get it. That's a freebie. Your sample, make sure you do your sample in order. We teach you the acronym for a reason because otherwise you forget some of them.
And you do. And that's my problem. That's how I always do my assessment. I'm not a good example to go by. I don't follow sample in order.
Neither do
I don't. But I still know, and my cheat is I have my computer and my report. That's where I can still go back and make sure that I can.
So I sit there when it's my call, I have a laptop, okay? I hold the laptop, my partner does patient care. I talk to the patient, my partner does the hands-on stuff. Gets me all my vitals, treats whatever my partner needs to treat, puts them on oxygen, puts them on the monitor, gets all my, you know, whatever, starts IVs, all that stuff. I sit there and I answer questions, or I ask questions in the order they pop up on my screen, which is not sample and OPQRSTU, okay? When I revert back to, I have to use paper, or my patient is very sick, I ask questions in the order of sample. OPQRSTU, I probably bounce around a little bit, but I try. But, like, you guys learn all these acronyms, and they're great. Memorize them. Like, we teach you, like, AEIOU tips for, you know, altered level of consciousness. Every time I teach AEIOU tips, I learn AEIOU tips again. Why? Because we weren't taught that in basic, intermediate, or paramedic way back then. I learn it every year, so I can teach you guys every year, and that's it. And it's gone after that, because I don't use it. I assess for all of those things by looking for things that I know cause altered mental status, but I don't use the acronym. We give you the acronyms to make them easier. You know, sample, when Matt and I started, was ample.
Yeah, it was just happening.
OPQRSTU was PQRSTU. There was no O, there was no U. We expand on stuff to make it easier for you guys, so use them. But that's, Matt's organized. He did pre-arrival, he did his primary survey, and then he went into his secondary after, you know, making his transport decision. Okay? And that's it. If you find a problem in your primary, fix it. If there's been a major problem in your primary survey, like you have to suction their airway, bag them, or you are controlling a major bleed or doing compressions, you transport right after them. If none of that happened and everything's kind of stable there, then you can do your secondary on scene, stay in play. Start asking some more questions, get some more information, then decide when that you're going to go. But as soon as he figured out she was potentially stroking or having a TIA, what did he say? We got to go. Okay? But I think you guys needed a demo of kind of what we're looking for.